When we think about the application of systemic therapy in patients with head and neck cancer, we really think about it as a function of disease setting. For early stage disease, stage 1, stage 2 patients, we really don't think about systemic therapy. Those patients are often cured with single modality therapy, surgery, or radiation. It's patients with stage 3 disease or stage 4 disease, and remember, for head and neck cancer, you can have stage 4 disease, 4A and 4B, and not have metastatic disease. So those are still considered locally advanced patients. And it's in those patients, stage 3 and stage 4, where we begin to think about the application of systemic therapy. Now, of course, we have a few options that have been validated with phase 3 data. The first and probably most common standard is cisplatin. That's usually delivered every 3 weeks in high dose, 100 milligram per meter squared, concurrent with radiation. Depending on the radiation scheme, we'll usually plan on giving 2 or 3 doses of cisplatin. The other option, of course, is cetuximab. Again, phase 3 data supporting its use, usually started a week before the radiation starts as a loading dose, and then continued on a weekly basis through radiation. There are also some other options. For instance, a European trial demonstrated that carboplatin 5-FU provides a superior overall survival compared to radiation therapy alone, and some, let's say, much less frequently used regimens that either don't have phase 3 data behind them or are somewhat idiosyncratic. Well, so in North America, I think the two most common uses of systemic chemotherapy would be cisplatin or cetuximab. Let's talk about cisplatin for just a moment, because there are 2 ways now that are commonly used to deliver cisplatin. I talked about the high-dose regimen, but there are also data, although much more limited data, for the weekly application of cisplatin, usually at a dose of about 40 milligram per meter squared. The reality is that we actually don't have a comparative trial that looked at high dose versus weekly dose of cisplatin. We have some data in other cancers, some data in nasopharynx cancer, showing that weekly is superior to radiation therapy alone, but we don't have anything comparing the high dose versus the weekly. Unfortunately, for those individuals or those practitioners who favored the weekly regimen, we're beginning to see retrospective and registry data that's beginning to suggest that the weekly regimen, A, may not be better tolerated than the every 3 week, and B, and most concerning, may not be as effective as the every 3 week. And so in my practice, I usually am using the every 3 week high dose cisplatin because most of the data continue to support that. Now, shifting gears a little bit from locally advanced disease to the recurrent metastatic setting, we really begin to think about different goals of therapy. Unfortunately, for patients with recurrent metastatic disease, usually they can't be cured. Some of them can be with either surgery or perhaps re-irradiation. But for most patients, we're talking about palliative systemic therapy. And there we think about lines of therapy, so first line, second line, and even in some patients, third line. For first line therapy, we do have an approved and validated regimen in phase 3 trial, and that is the EXTREME regimen. That's a triplet regimen combining platinum, either cisplatin or carboplatin, with 5-FU and cetuximab. And that demonstrated an improvement in overall survival versus platinum 5-FU alone of about 10 months versus 7.5 months. And as I said, that is an approved regimen for first-line recurrent metastatic head and neck cancer. The reality, though, is that, at least in the United States, that's a regimen that's not often used. And I would estimate probably somewhere in the range of about 20% of patients end up getting the EXTREME regimen for first line. In the US, the more commonly applied chemotherapy is a doublet regimen, often consisting of a platinum and a taxane. And the reason behind that is that, first of all, the feeling is that this is a palliative setting, and we really want to preserve quality of life as much as possible. Secondly, platinum-taxane combinations are clearly effective. Good response rates, at least in phase 2 trials, evidence of good overall survival and progression-free survival, evidence of symptom control or quality of life, at least management, and that it may be wise to preserve some of the agents for second or third line. And so common practice in the United States is to use a doublet in that first line. In the second line, most patients are usually being treated with single agent cytotoxic or cytotoxic chemotherapy or cetuximab. Now, of course, in 2016, that changed completely. And it changed because of immunotherapy and the anti-PD-1 antibodies. We saw data first with pembrolizumab and its efficacy in usually second line or third line patients, patients who were refractory to platinum, and in some cases refractory to both platinum and cetuximab, demonstrating response rates, good progression-free survival, and good overall survival in non-randomized trials. And then later in 2016, we saw the first randomized study in squamous cell carcinoma of the head and neck using nivolumab, demonstrating an improvement in overall survival versus single-agent therapy. That was an investigator's choice of either methotrexate, docetaxel, and cetuximab, and nivolumab in patients who were refractory to platinum doubled overall survival, going from about 17% to 36%. Unprecedented in patients who are platinum refractory squamous cell carcinoma of the head and neck. And now, for many patients, if not most patients, in the second line for recurrent metastatic disease, we would be using an anti-PD-1 antibody.
Since 2006, cetuximab has been an FDA-approved regimen when combined with radiation therapy for locally advanced head and neck cancers. We have experience with a large number of patients receiving cetuximab and radiation for upfront curative disease in the locally advanced, previously untreated setting. Very commonly, we use cetuximab as a replacement or a substitute when a patient is not eligible to receive cisplatin, and somebody with kidney disease, renal toxicity, neurologic symptoms, or an older person older than 70 years of age. So an appropriate candidate to receive cetuximab would be somebody who is not eligible to receive chemotherapy like cisplatin. Now, people often ask whether HPV-positive patients or HPV-negative patients should receive cetuximab. It turns out that, although not prospectively determined, retrospective analyses of large numbers of patients who have received cetuximab demonstrate that both HPV-positive and HPV-negative patients benefit by adding cetuximab to radiation therapy alone. It turns out that HPV-positive patients benefit more, but that may be because HPV-positive patients benefit more no matter what treatment we give them. So far, HPV-positive patients benefit dramatically with survival rates in the high 80s at 2 years. HPV-negative patients, although they benefit some, their overall outcome is not quite as good. And so most clinicians would try best as they could to use cytotoxic chemotherapy, since it may be more effective than cetuximab for HPV-negative patients. Cetuximab is also approved in the recurrent and metastatic setting. The regimen combining with cetuximab with platinum and 5-FU chemotherapy is called the EXTREME regimen. And the EXTREME regimen was FDA approved in the US in 2011, combining cetuximab with platinum 5-FU, where it showed a survival advantage over the chemotherapy alone. It also permitted months and months of maintenance, and so that's probably the best population for maintenance cetuximab therapy, is those who have received the EXTREME regimen for recurrent metastatic disease, combining cetuximab with platinum 5-FU chemotherapy, then continuing with an adjuvant maintenance phase of weekly cetuximab until disease progression.